Outstanding. Okay. Well, again, good morning, everyone. Welcome to the third meeting of the Maryland Oral Health Task Force. Welcome to our task force, as well as Delegate Bagnall and our invited guests. I do want to kind of give you an overview of how we want to proceed. Excuse me, this morning. We'll begin with some announcements. Then we'll get into the discussion of the various subgroups and homework assignments, as we refer to them, amongst our task force members to begin the granular work related to the lines of inquiry that we've opened for the task force to accomplish our deliverables. After that conversation or discussion, we have two invited guests that will make presentations, and then we'll have announcements to give you all a forecast and a schedule for the remainder, I should say, of the year, as well as a preview of what we intend to do going forward. But with that, I'd like to turn it over to Dean Reynolds to see if he has anything he'd like to add. Hearing none, I will presume that we may proceed. One announcement I did want to make from a departmental perspective that I think you're all aware of is that on the 5th of November in the Maryland Register, there was a transmittal related to dental coverage of postpartum that becomes effective as of the 15th of November. Our department and my shop have put that out, and it has now gone through regulatory publication. So make yourselves all aware of that, a great benefit that we're able to offer to the beneficiaries here in Maryland. With that, I would like to move on to discussion of the task force work plan and the assignments there too, who's associated with what, and what we're trying to do and accomplish in that regard. And again, I'll invite the dean to weigh in here as we go through. So Lindsay, I don't know if you're able to pull up the grid of our fielding assignments. And while Lindsay's doing that, I'd like to also note that we have assigned proactively various task force members to groups to even it out. Again, the groups are associated with the work plan that we agreed to previously. And the intent is for the task force members to break down into smaller groups to begin the research, begin the thought process on the scope of what recommendations we might want to seek out for each individual group. So as we walked through the work plan previously, the general thinking is to have identified the groups, then identify the barriers. And again, those barriers are pretty broad, logistical in terms of transportation, geographic access, so forth. As those hurdles are presented to each group, and how to overcome them, what we need to do, what investments need to be made, what changes need to be made in order to remove those barriers for those groups and access to dental care. And that's the flow by which we would like the groups to proceed. Obviously, thank you, Lindsay. Those work groups will need additional data, and we're happy to try to do some research and get data if it's possible. We also want to make sure that we base those not on anecdotal evidence nor gut feelings, but bona fide data points, studies, real life examples that work perhaps in other jurisdictions, and that are not just truly aspirational. Those that have shown efficacy and efficiency in prior use. Dean, I don't know if you want to add to what I've just stated. Okay. Any questions on that before we go into the work groups? Okay, hearing none. So again, the work groups are expected to meet asynchronous to these sessions. And what we'd like to do is have the work groups come back and report in to subsequent meetings. Given the fact that we have 6 subgroups, what we'd like to do and what I'd like to present to the task force as a going forward work plan is to have these groups meet asynchronous to the to our sessions here. And then as we're all seated in our next meetings, everyone takes 10, 15 minutes to come back with their findings, their thoughts, their ruminations on their particular topic of inquiry, and then we can bring it up to a larger group of discussion. And so that way the work's getting done and everyone's having a visibility into the decision-making process, as well as the evidence presented, and to make their own recommendations, even if they're not present or associated with a particular work group. So that way we feel that there's broad participation across the entire task force, and it gives everyone obviously a chance to weigh in, and it presents the visibility and transparency that is required of this task force. Any questions or suggestions to that approach? Okay, hearing none, I know that Lindsay had sent out an email to each one of the subgroups with for lack of a better word, the homework assignments, the general questions that we would like to have asked and answered. Feel free to come back to the task force staff as well as the co-chairs in terms of requests for data that we might be able to gather from state sources, external sources. We have a fairly robust, again, resource library that we've begun to accumulate that you all have access to. We continue to add to it. And I'll make these have further discussion in the announcement section that we intend on inviting additional guests. We have a guest list, if you will, of folks that we think would be informative to our deliberations. And I'll talk a little bit more about that later on during the task force conclusion. Questions so far? All right, so to set a little bit of milestones, as the task force has agreed previously, and again, for those of you who are not able to attend the additional meeting that we have scheduled for December 2nd, I believe, Lindsay, December 2nd and December 16th. December 16th will be our standing vote meeting, although I don't believe there'll be anything we have to vote on at that point. They are all recorded, so folks may go back to the material and to the audio recordings and video recordings. But what we'd like to do is have some feedback and some general thoughts from each one of the subgroups when we next convene. I would suspect that probably December 16th might give people enough time to get together, get some loose initial thoughts in rather than the second, given the fact that we have the holiday approaching. So I would ask that unless there's objection, that each one of the subgroups comes back on the 16th to make presentations, at least on their preliminary findings or preliminary thoughts when we next convene and gavel in the entire task force. Is that reasonable? A reasonable expectation for folks? Is everyone about a month?
Yes.
Yes, that sounds reasonable.
Great, fantastic. And then we will proceed in that manner. And then what we'll do is every standing meeting, we will have the report out from the groups, and there'll be work done in between. As we approach December, obviously the extra meetings that we've requested in order to kind of continue to get work and to continue to gather input from outside sources and so forth. We will probably not be able to do that, nor do I think anyone has the appetite to do so during time of session. So between January and April, when everyone's got a lot to do across the board here, from private practitioners to the delegates to the staff and so forth, we may not have as much frequency of meeting, but we will try to have some meetings in order to keep the momentum going forward. Dr. Koyman, you have your hand up.
Yeah, sorry, I don't mean to take a step backwards or anything. I didn't have that in my notes when I was looking at the list. With the group that's Medicaid, people that are eligible for Medicaid, I mean, doesn't that kind of, again, I'm not trying to go backwards a little bit, but doesn't that encompass the groups? I mean, really, pediatrics is the group that it encompasses Medicaid. So wouldn't it make sense to have less groups and maybe split those people up amongst the other groups so that way we're not doing double work?
Well, I would ask if you're asked.
Oh, we're going to go back to our chart.
Thank you. Well, I would suggest that, while Medicaid does cover a quarter of all Marylanders, it's not completely exclusive. Now, there will be some folks that are groups that may be uninsured that aren't covered under their parents. For example, employer-sponsored coverage may not be eligible for CHIP and a kind of gap. Of course, there's a gigantic overlap given the share of the Medicaid population that is moms and kids, for example. But I would posit that we should keep them separate, although they would obviously naturally overlap. I mean, these are all Venn diagrams. They all overlap.
Right, exactly. They do, yeah.
But I'm of course open to the suggestion. We've, again, going back to kind of founding principles, we wanted to try to establish buckets and swim lanes in order to channel the work, given the breadth of concerns and issues and interests that we have, and to try to add an architecture around it. But your point is taken, and I would like to hear from the other members of the task force, with the caution that I don't want to too finely dice the groups that we already have established.
I think
Right.
the same thing could be said for the immigrants in Medicaid. I'm on the immigrants group here, and a lot of immigrants are under the Medicaid program, but I think the immigrants have very unique needs, even though they may be covered under something, as you said, with the Venn diagram things overlapping. I have started to do some work with that, and their needs are definitely unique. So I think there should be a select group there just for the immigrants. So.
Right. So, for example, we call them XO2, XO1 groupings in Medicaid, where you have emergency services covered for immigrant populations that are undocumented. If you have an undocumented population, they're not able, to avail themselves of Medicaid services with federal match, unless it's for emergency services, and it may be vis-a-vis state dollars. And so, again, there are overlapping Venn diagrams, but not completely exclusive. They don't completely overlap to one another. And again, Dr. Quitman, very well may be that the pediatric population is disproportionately accessed through Medicaid as a payer. But it also may be that vis-a-vis the schools or school-based health centers or what have you, that where there may not be Medicaid money flowing, or there may be money flowing that's set aside to have access to those who do not qualify. And again, that's the uniqueness of our balkanized healthcare system, is the different silos and overlaps in terms of
right
and who pays.
I think just my one concern is right now, and I know we're discussing it, our Medicaid system is Maryland Healthy Smiles, which is children. And so we're trying to work on that. I mean, we're trying to work on that. And, there may be some other things that come into the mix a little bit here, and I worry a little bit that if, we have two competing, Medicaid and pediatric competing, not against each other, working together a little bit more. I just worry that as we get into having this open discussion, that all of a sudden there may be, people working on two different avenues that are maybe going a different direction when we're all fighting for the same population, if you know what I mean.
No, I understand. So let's take the threads, and then we'll lace them up as we go along. I think what you work on there, Jennifer Bremen, Dr. Backley, Dr. Woodward, Dean Shiflett, cross-pollinate. Everyone has each other's emails and say, hey, this is what we're looking on. By the way, I know that you're all working on this. Can we import this? And that way there should be cross-communication between the groups, so that when everyone kind of comes back with their 10-minute presentation, 15-minute presentation, we can weave that together and start that tying the knots. And you very well, as this is iterative, right? At the end of the day, we may subsume one to the other. But let's, I would, again, suggest that we at least start at the starting point and see how it works. We'll do the test kitchen. Dr. Romaine.
No, I would agree with that suggestion, Alex. I understand Dr. Hoyman's question, because it does thread through all of the subtopics, but Medicaid is and of itself something that we certainly don't want to look at just from the top layer. I think it deserves its own group to really deep dive into it and then see how they cross-pollinate. Because as we said, though it is mostly children, it is now, as of November 15th, plus the 60-day postpartum pregnant women and young mothers, new mothers, and it is also the dual eligible. So though we will all be looking at Medicaid through our own sub lenses, I really think it deserves its own subgroup. Thank you.
And naturally, there's going to be Medicaid's naturally going to be a gravitating point, given the fact that it is the largest payer, besides the employer space, obviously, and it tends to be the easiest vehicle by which to add things to. But that said, there's political, fiscal, administrative challenges with anything that you do in that regard. And so I don't want to make Medicaid the only vehicle for change in oral health, given the fact that the mandate of the task force is broader than just the Medicaid population and where we can move levers. Other comments or questions? Okay, well, then I'd like to move on to our presentations, if we could. And we have two guests today that are bringing presentations to the task force that, again, we've selected and invited to come to help inform the conversations against these subgroups and the natural lines of inquiry that we've established. And our first guest will be Bernard Lapine, the Director of Regulatory and Legislative Affairs for Highmark United Concordia. And our second guest will be Emmy Augustini, the Executive Director of National Associations of Dental Plans. Am I pronouncing it right there, Ms. Augustini?
You got it.
Outstanding. Okay. And then what we'll do is we'll take a break in between the presentations to entertain questions from the task force. But before we get into that, Dean Reynolds, anything you wanted to add?
Not at all. Good morning, everyone. Thank you so much for joining. I apologize for being delayed a few minutes. But I did want to just simply comment. I hope and I think there's great value, as Alex suggested, and having crosstalk among the groups. I think we're going to discover that we can work in concert, and those dialogues really be central towards that end. So thank you.
Thank you, Dean. So with that, Lindsay, Matt, would you like to introduce the speakers, give a little bit of insight as to what the invitation and what they're going to talk about today?
Sure. Yeah. Thanks, Alex. Hi, everybody. I know a lot of you and some of you I've seen before, but I've never actually met. My name is Matt Celentano. I am the Executive Director of the Alliance of Maryland Dental Plans, which is the sort of trade association for dental insurance, dental coverage companies that operate in the state of Maryland. So I actually was at the table testifying in favor of this bill for a couple of years, always asking for one small amendment to add a dental plan because carriers are a part of the way we move forward. And I think it was seen as a friendly amendment, and I'm super thrilled to be here with you guys today. As you know, we've made tremendous strides in Maryland. I don't need to reiterate that to you guys. I don't need to give you context. You all know, but carriers are here and willing and really looking forward to making continued strides. So I asked two of our members to come present to you guys today when we talk to the co-chairs. And thank you once again for the invitation. I brought some of the experts because I know a lot of stuff about dental coverage, but it is better to hear directly from the companies and from the national folks that will be able to give you broader context. That being said, I will probably drop my information into the chat at some point here. If there are follow-up questions after this meeting that I can answer for you, or if you would like to have a chat on the side, I am willing and able. Please do not hesitate to reach out to me. Alex sort of introduced everybody already, but first, I think you're going to hear from Emmy Augustini, who is the Executive Director of the National Association of Dental Plans. So she's going to be able to give you perspective of coverage across the entire country. And then you'll hear from Bernard, who is with United Concordia, which is a company that operates and sells coverage here in Maryland a lot. So we wanted to give you two ends of the spectrum, the national and the local. And then if there are questions in the middle, I will help try to answer those, but I wanted to make sure that you heard straight from the expert horse's mouth, so to say. So with that, I won't take any more time and I will let Emmy take it away. Thank you for the opportunity.
Great, thank you, Matt, and good morning to everybody. Really appreciate, of course, the introduction, but also the invitation. I'm very happy to be here this morning and share information and data that we have at the National Association of Dental Plans and try as best we can to assist in the important work that you're doing. NADP is a nonprofit trade association representing the dental benefits industry, and our mission is to improve consumer access to affordable, quality dental care through advocacy, research, and the promotion of dental benefits. And embedded within our mission here is really a good summation of our core services and what we do. Like most trade associations, NADP does government relations, research, education for and about the industry. We conduct research on sort of the basics of the industry, like enrollment, premiums, networks, claims processing, just as examples. We also survey employers and consumers as purchasers and utilizers of dental benefits. And you'll see a cross-section of some of that research today. And I won't really linger much here, but I will note that NADP members provide dental benefits to a sizable share of the population that has dental benefits in this country. And there are a variety of types of entities that participate within NADP. As Matt has said, I'm the executive director of NADP. I've been in this role for 2 years of the 9 years that I've been with the association. But that's enough about us. Let's get to the fun stuff. So much of the data and information I'm going to walk through today is from the national perspective, but I do have some data specific to Maryland that I'll be able to share. I think Bernard will have some information and perspective as well from their experience at United Concordia. But let's just start at the kind of the highest level. How many individuals have dental benefits? At the end of 2019, this number was approximately 263 million Americans. And this fits into an overall trend line of growth of dental benefits enrollment that you can see here. And if I go and reach farther back, our data from 1995, it's not on this slide, showed 45% of the population is being covered by dental benefits. Then we went up to 57% or so in 2000. And then of course, for 2019, the number I just cited represents 80% of the population having a dental benefit. And in that time frame, and what you see on the slide, I think we can identify a couple of broad trends or make some observations. So one that we can identify is the relationship that exists between full-time employment and dental benefits enrollment. So the Great Recession of 2009 and 2010 did impact enrollment in those years. In fact, down to 55% of the population covered. And it did take several years for the market to recover to pre-recession levels. And the connection that we see that exists between employment and enrollment isn't necessarily surprising, given that anywhere from 93 to 95% of Americans with private coverage get their benefits through their employer. And now if we keep looking at the chart though, as the economy grew through 16 to 19, and with a strong employment market, the commercial dental benefits segment did grow post-recession. We are currently, right now within the association, we are analyzing the data for 2020. So unfortunately, I don't have that to share right now, but of course, we know there was some churn during the year, which very well could be reversing given the current workforce conditions and what employers are needing to do to attract and retain their employees. But on that, I think I would just be conjecturing. So I will talk instead about another trend that we can see here. Our data will also show the growth in dental benefits enrollment through public programs. At the end of 2017, about a quarter of the population had dental coverage through public programs, and about half had it through the private coverage. Between 2014 and 2017, the population with dental benefits through Medicaid more than doubled, while the population with dental benefits through Medicare Advantage programs actually tripled. So I'm going to talk more about public programs in a later slide, but it's certainly, I think, noteworthy and something that you could see here as well as a trend. But for now, maybe what I'll do is give another sort of way to view this data. I think this chart will further clarify that commercial segment into the employer-sponsored and individual coverage there on the left side. It is clear that the employer segment is the vast majority, at least within the private dental benefit space, because that's the primary channel for benefits and coverage, again, in the commercial space. An employer of really any size will consider benefits, dental benefits included, as a part of their overall compensation strategy and within their strategies to attract and retain employees, and also to take care of those employees and their families. Some employers in this darker blue pie piece to the far left will, they'll self-fund. Maybe they'll work with a carrier to help them pay the claims. Some will work with a broker to find the best options for them, or work within a PEO, even a preferred employer organization, or they'll work with a carrier directly. And dental benefits across any of those mediums to find benefits have, and they continue to be in really high demand. So dental benefits are the most requested benefit after medical or health benefits and pharmacy. And something that I'll note on the next slide as well, the actual policy or the product that's offered and that folks enroll in, 99% of the time, it's a separate policy from the medical policy or the plan. It could be, offered or maintained through the same carrier that provides an employee their health coverage. Maybe it's the same carrier that provides the group their life insurance, or perhaps it's another carrier altogether. Employers may give employees multiple options when it comes to their dental plans to fit their needs. There's been some good bit of variety here, and that's worked well for employers, employees, and their families, and supported a pretty competitive marketplace. And I will note that employees who have dental benefits through their employers will also have that benefit, generally speaking, available pre-tax as they would for their health insurance. And again, I'll cover public programs here in a minute, but I think it's important also to acknowledge there's this gray pie piece here up near the top, or 20% of Americans without dental coverage. In one sense, I would say this pie chart and the previous slide, they represent improvement over time. The dentally uninsurance rate has dropped. It used to be roughly 4 times the medical uninsurance rate. Now it's 2 times the medical uninsured rate, even though that number has also gone down. But there is absolutely still more work to be done. And the next slide, I think, maybe further clarifies just the previous ones, but you can get a sense again of the share of coverage that is through employers. And I'd say it's probably good to note that what we call a large group over on the left-hand side means any business greater than 50 employees. But I think if I were to note 2 things, it's the fact that dental policies are sold and maintained separately from medical, with only, again, 1% of enrollment being through a truly embedded sort of policy. And that maybe on the right-hand side, we can see the relative ease at which larger firms or employees with scale can offer dental benefits, and that smaller firms may have difficulty or see less value. I would say caveat that as well, though, that these numbers as well have grown over time. And so let's talk about, what are these plans even looking like when I talk about enrollment in dental benefits or dental products? There are about 4 different or key types of dental benefits plans. So health maintenance organizations, HMOs, preferred provider organizations, PPOs, dental indemnity plans, and discount dental plans. I think it's pretty plain to see here within that large green segment across the years. PPOs continue to be the most popular type of dental benefit plan by a pretty large margin. So these plans contracts with dentists, and they obtain a discount from overall fees. And the dentists then gain access to new patients that are enrolled in the plan, and enrollees, in turn, they receive value from the discounts when using contracted or in-network dentists. But they can go outside of network, maybe with some reduction in coverage. And dentists are then reimbursed on a fee-for-service basis after the care is provided. PPOs have I think, largely been popular due to broad access to the network dentists and the ability as well for enrollees to be able to self-refer, which you usually couldn't do in an HMO. And of course, access to discounted rates on services. But if we talk, and sorry, I'm looking at the chat just in case there's anything from me. Okay, I see a question. Do we have date on no coverage broken down by age? I'll have to go back and look. It's a great question, and check with my research director. So good question, and I'll jump right back in. So what I talked about, sort of the network configuration or the plans on this slide, but kind of again, what does the coverage generally look like? We can talk, I think, more here about structure. Dental plan premiums are anywhere from 1/12 to 1/20 of your medical plan premium. And those premiums tend to grow much slower over time, increasing maybe by 1%, 1 or 2% per year, sometimes seeing even decreases in a few years. It's a very competitive marketplace. It is a voluntary purchase, so it's not a mandated purchase. And employers and consumers are very price sensitive relative to dental premiums. Dental plans, they will generally cover 3 or 4 categories of service at different cost sharing levels. So most plans cover 100% of preventive care and apply cost sharing to other levels of care. That preventive care will include periodic oral evaluations, x-rays, and sealants for kids, just as some examples. But in addition, if I'm thinking about preventive care, if there's a plan deductible, it will usually not apply to preventive care either. And there's a lot of emphasis within dental plans on prevention. It's a real focus within the benefit, and it reflects the fact that the 2 primary dental diseases, so decay and gum disease, are largely preventable, and the emphasis or the desire is to support enrollees in getting in to see their dentist on a regular basis to avoid, of course, pain, but also the development of more complex and costly conditions that require costly procedures over time. But again, if I'm thinking about dental plans, the other categories of services that are covered are sometimes called basic or major, and sometimes ortho as well. Basic includes things like extractions or fillings and periodontal treatment for gum disease. Basic would be typically covered at about 80% when in network. Major procedures are the last category and can include services like crowns, bridges, dentures. They're usually covered somewhere around 50%. And most PPOs will have an annual maximum benefit of some type. Now it is generally about $1,500 or more. In the past several years that we've been collecting data, about only 5% of enrollees actually ever reach that annual maximum for in-network services. So as I think about dental plans and the actual benefit, that's probably the highest level that we could look at these products. There are some emerging trends in the space, given the growing research and evidence about the connection between oral health and certain conditions like diabetes. Plans have increasingly been covered what I might call enhanced benefits or additional coverage for something like a third cleaning or periodontal care for enrollees that have diabetes, just as an example. We've also observed, just thinking again about trends or what could emerge in the future in this space, our quality measures, of course, are being developed. Diagnostic or diagnosis codes in dentistry are beginning to be utilized. Those will probably see more developments begin to emerge first in the public program space, which actually, in terms of public programs, I did promise that we would swing back to. So let's kind of do that now and expand a bit. The growth in public programs enrollment, I would say, has some additional historical or public policy context. So at about the time that dental benefits enrollment was recovering from the recession, the Affordable Care Act's health insurance exchanges came online in October of 2013 for 2014 coverage. And part of the effect of the Affordable Care Act and the exchanges was actually that many people discovered in going onto the exchanges that they or their children were eligible for Medicaid and CHIP, incidentally, which could have precipitated some of the growth that we saw in benefits enrollment via public programs at about that time. But I think of probably a much greater impact was the combination of the expansion of Medicaid benefits under the ACA in most states, coupled with, at about the same time, additions of some level of adult dental services in Medicaid. So as more adults were able to enroll in Medicaid through expansion, this provided access to dental care if it was already provided to adults in the state. But this effect was also amplified in states that started implementing a dental benefit or made the dental benefit more robust. Perhaps they had something that felt more like an emergency dental benefit, and it made it more to a limited one, or perhaps moved from a limited benefit to a more comprehensive benefit, for example. So that's, I think, a driver of a swing here. Looking at 2019, there was some small percentage decline in public benefits as the economy started to grow. And it's not surprising. Again, as full-time employment goes up, individuals are more likely to get benefits through their employer. If we home in on Medicaid specifically, the chart on the left is a reminder or shows that the pandemic had a huge effect on Medicaid enrollment and eligibility, generally speaking. And until the last 6 years or so, Medicaid and CHIP, again, the dental coverage was primarily available only to children and pregnant or new mothers. That is clearly changing. The chart on the right shows that the Medicaid and CHIP population and the dental coverage that's available to them through the program. For adults, the situation in terms of coverage has improved, but I'd say it's still a patchwork across the states, which results in the totals that you see in the bottom half of this pie chart, indicating those adults in Medicaid with access, you can see, to maybe more comprehensive or extensive dental benefits, or those with more limited benefits or none. And the data here on the right is based on that we've compiled from CMS. Another avenue for dental coverage has been, of course, the exchanges, where standalone dental plan coverage is offered. Purchase of those plans generally increased through 2017 with some small decline after that. Some of that could be attributed to political forces, but the growth in employment-based benefits could have also been a driver. For the years that we do have available, another sort of data point that's not represented here, 3/4 of dental plan selections on the exchanges were for what I call the low actuarial value level. So for dental plans on exchanges, there were 2 AV levels. You could maybe call it silver and gold. And the vast majority of those that selected a plan chose the lower cost product. On exchanges, you're also more likely to find more HMOs or EPOs being offered, just speaking to what I mentioned before on the previous slide around PPOs and HMOs. Another important program is Medicare. And our consumer survey does ask questions of those older than 65. The majority of whom, or slight majority of whom, report having a dental benefit either through Medicare Advantage or perhaps through their employers. So it could be a retiree program that they have access to, or they're still working or another individual product that they've actually gone out and purchased on the broader commercial market. And I would say now close to, if not more than 90% of Medicare Advantage plans include a dental benefit. And those benefits are becoming, more comprehensive over time. Medicaid isn't noted here in our data, but it's another way to fill the gap for those who are dually eligible for both programs. And I think there was a question about sort of plan or network type in Medicare Advantage. And in general, I think it's a type of PPO, but I would need to go back and double check because there may be a lot of regional variation there. Medicare Advantage products and carriers are constantly monitoring the demand for benefits and access within their regions, states, and even smaller sort of geographic areas. So I would need to go back, and I always want to double check things. So I will say, though, just on the question of Medicare, or on this topic at the federal level, there was a recent discussion as part of the Build Back Better legislation that's being considered to look at a dental benefit in traditional fee-for-service Medicare. The current version of the president's proposal or framework, as well as the House's draft, includes a new benefit for hearing for Medicare, but not for vision or dental. Finally, some data that's specific to Maryland. So what you see here is a breakdown of information from our enrollment report that's specific to Maryland. Our reporting finds that 74% of the population has dental benefits. I will say, I dug into this a bit before the call. I spoke with our research director. I think this number is a little bit lower than actual in the state. So we generally advise with our state fact sheets. I think you may have one from our 2021 fact sheet. We have ones from 2020, 2019. We have reports for each year on enrollment. We generally advise not to look at state data over the years, specifically at the state level, to identify trends given differences in which and how carriers report from year to year. But I went ahead and I did it against my own usual advice. And for several years prior to this, the Maryland data was closer to 80%. So I talked with our research director a bit. Our data, of course, can fluctuate based on how and which carriers report, and there can be shifts due to the carriers who are reporting, maybe if there are big clients or programs that shift between plans. We do try to address that in our analysis, but it's not always possible or perfect. But I say that whether the number is higher than 74%, I think there will be and continue to be opportunities for greater coverage. And in my limited view, and I certainly appreciate the expertise of my colleagues and everybody on the task force here, and an adult dental benefit in Medicaid is to me a definable kind of set of opportunity. If if I think about the math here, I looked it up, there must be more than 500,000 adults served by the Medicaid program in the state. And I understand there was a pilot program as well, which looked at dual eligibles for Medicaid and Medicare, which could also benefit from an adult dental benefit in Medicaid. So that's something that I contemplated a bit in pulling this data. There is some additional state level data on the fact sheet that we'd sent over or has been distributed or will be, and it highlights some other data. We have certainly many other reports of which we sometimes have state level data. So, for now and in the future, if you have questions about anything we've talked about, I can try to see what Maryland data we have or can find. And I've talked a bit about enrollment, and it is, I think, an important indicator given the connection between having coverage and care-seeking behavior. So those who have dental benefits are up to 2 times more likely to go to the dentist. Parents with coverage are more likely to take their children to the dentist And that is true in Medicaid as well. There was a really recent study published in Health Affairs that found adult dental coverage is associated with a statistically significant reduction in untreated caries among children after Medicaid enrolled adults had access to coverage for at least 1 year. So I think that was maybe in the most recent or the one before edition of Health Affairs, really good research. And there, of course, are really important correlations and connections between oral and overall health. And Bernard will speak to some of this and information that UCD has published. But, you know, another study recently found, it was analysis out of Medicaid in New York. Researchers there found that those who received preventive dental care had lower emergency department use rates, and the costs for their total health care were lower. So meaning dental coverage in Medicaid can lower costs for the universal program. And again, if I speak or think more about the oral overall health connection, a couple of indicators that we follow are included on this slide to essentially capture consumer awareness of the links between oral health and medical conditions seen on this slide. It has been slipping over the past few years. I think this is an important aspect of how individuals will view the importance of going to the dentist. I haven't actually posted up here data from many years past, but the Surgeon General issued an important oral health report in 2000 that emphasized the connections, and I think it had an impact on the public consciousness. The last administration largely completed another oral health report from the Surgeon General, and the new administration has taken up that work, and it's really critical that the information be released. Unfortunately, in some ways at least, the new report will no longer be issued as a report from the Surgeon General. It's going to be coming from the National Institutes of Health and NIDCR. A Surgeon General's report, it kind of has quite a bit of national and even international significance. So it is unfortunate in some ways that it won't be released from the Surgeon General, but we do know that the anticipated publication from NIH, they're looking at mid-December, or at least before December 31st. I'm part of a couple of stakeholder groups in the oral health space. We are beginning to sketch out ways to promote the report and its findings, and ultimately, make an impact on these numbers on the slide. And more to the point, the report as it gets published over the next month is something that this task force certainly could look forward to seeing, hopefully before year end. But that really concludes what I had prepared or information that I had pulled. I think there's definitely more data where this comes from, and I've written down at least 2 questions that I would like to double check first. On the age breakdown of enrollment, the data that I had included on a previous slide is based on our enrollment report, where we survey carriers about the enrollment they have. We do not, I believe, break that down or collect information from carriers by age. However, we do conduct the consumer survey and report, which gave us the information about those older than 65 on one of the previous slides. So I can see what, if anything, we have there. But I imagine there are other resources out there as well, including some of the household surveys that CMS will do about coverage. So I think there's things out there that we could look for. In terms of if the question was about children who don't have coverage, that number should be at 0. But it should have gone down over many years. And in particular, what made a big impact was implementation of CHIP. And then again, I mentioned previously about the exchanges as those came online. Parents who looked for coverage for themselves or their kids, they might have become aware about the coverage that was available in Medicaid and CHIP for their children. So that's where we saw some impact for kids when the ACA was passed and implemented. Okay, so I see some stuff in the chat, and then maybe some hands that are raised. So I can happy to try to answer some questions. Of course, I would also say Bernard's presentation will give some more perspective and sort of anecdote, and also I think more specific information from Maryland than I would have. So happy to pass it back.
Thank you, Amy. We'll go with questions first for Dr. Doring and then Dr. Clement. Dr. Doring, please.
Thank you for your presentation. My question on the breakdown on the non-coverage was particularly look at middle-age adults, and there seems to be a kind of a disconnect with the importance of oral health, and then also in seniors, since I'm assigned to that elder particular group. The other question I had, and I have a letter from July of this year from a carrier that begins with a letter C and ends in IGNA. It says, based on our review of dental costs in your market and your current contracted fee schedule, we are writing to amend your contract by assigning you a revised fee schedule. And it kind of breaks my heart in the COVID-19 to tell you that this provider had the fees slashed. Is this going to be an ongoing trend, and are other carriers contemplating doing this? Because it really hurts at a time when we're trying to retain employees and provide care for the patients as we're coming out of this, hopefully coming out of COVID-19. So thank you.
Thank you, Dr. Doring, and I really appreciate your comment and the situation you're describing around the pandemic. Unfortunately, as the National Trade Association, we do not collect information on reimbursement. And it's also not something that as a group of carriers or within a market of competitors that we can actually even discuss. There's a lot of antitrust concerns there. So it's hard for me to speak to trends without necessarily having the data, although I think Fair Health has been kind of a good resource as an organization that had to or was established at the outset based on, I think, a situation in New York and a law that was passed to collect information on reimbursement. So there could be trends there. It's just unfortunately the way that a trade association operates and the way that mine does, we don't collect information on reimbursement.
I mean, this is Matt from Maryland too, and Dr. Doring, same thing for the local Maryland Trade Association. I have no idea what goes into contracts or reimbursements. It's just an antitrust thing. But that being said, if you would like to contact me on the side about company X and your sort of grievance with the procedure or their correspondence, I'd be happy to try to create a conversation for you with that company.
Yeah, this is Alex. Obviously, I don't think our speakers can talk specifically about practices individual from companies, since at this point we not yet had a company that has come present individually. But one of the things that's kind of the obvious elephant in the room is the fact that COVID has mucked up actuarial assumptions across all different types of somatic and behavioral health services, such that fee schedules, capitation rates, and so on and so forth are being adjusted to reflect changes in utilization that may or may not persist going into next plan years. So that's probably, I would suspect, if I were to hazard guess, where some of that is, but that's a little bit of field of where our lens of inquiry. Dr. Clement, please.
Thank you. Thanks for taking my question. My question, it kind of dovetails on that a little bit. I was wondering if there's statistics that you have, not about the number of people that are enrolled in dental programs, but more the number of providers that are enrolled in programs and where that number is going, because, and I know we don't have 2020 numbers here, but my feeling of what I'm kind of hearing is those numbers are going down significantly as far as participating providers go. And I wondered if you had data on that.
We do have a network statistics report that we release annually, and we have not seen a decrease to that point. So what we're reporting on is kind of the number of dentists that are listed within networks and directories or provider directories. And we have not seen a significant decrease or change in either direction. That being said, I could pull it again just to double check myself. But then you're right that we don't necessarily have information up to the minute. So it would be important, I think, to see, and to your point about a potential trend, to see information from moving forward through 2021, which we may not be able to report until 2022.
And then just as a data point, does that also show whether those providers are actually taking patients, like new patients, or does it only show that they're in the directory as being providers?
Our report does not include whether or not a provider is accepting new patients. It's a good question. Thank you.
Dr. Romaine.
I appreciate your presentation, Emmy. Thank you. My question is about Medicare Advantage.
Yeah.
I see that you mentioned that there are about 70,000 Marylanders who are currently signed up, but I know that's not in every county. In my own Allegheny County, where we have about 16% people in poverty, it's not available. So could you comment on why Maryland has kind of fallen so far behind on opening up Medicare Advantage and the dental plans that would go along with that? And then I have a follow-up question.
So to clarify or ask a question to your question, and because I couldn't hear you very well, are you saying that in your county, the Medicare Advantage plans that are available for whatever reason generally don't include a mandatory or voluntary dental benefit?
No, I'm saying, like, for example, Medicare Advantage plans aren't available in my county.
Oh, at all? Got it.
There are only some. Like, this is a newer thing. As I understand, Maryland is one of the bottom 4 states in availability for seniors to sign up for Medicare Advantage and the subsequent dental plans that go along. Mm-hmm. So I just wondered if, like, 70,000 in an entire state seems fairly low as far as number of people who have signed up for Medicare Advantage. I just didn't know if you had any comments about that or any observations from the national organization that you're affiliated with.
Yeah, so again, Medicare Advantage can be fairly regional, and in that way, I can really only speak to, in some cases, the inclusion of a dental benefit within Medicare Advantage. So I would be interested, honestly, to learn more about the dynamics in Maryland as it pertains to just carriers being able to offer in the Medicare Advantage space, period. So it's almost, I don't have a clear picture as I would like to be able to answer with any great specificity. But I don't know if Bernard or Matt has any other ideas, but it's a really great question and line of inquiry for sure.
This is Alex. I can take actually a stab at this if you like, unless Matt, you want to go for it.
I was going to go with general thoughts, but please go, Alex.
Sure. So Dr. Romaine, so obviously Medicare Advantage is I think I put this in the general chat, and I don't want to get too didactic, but for the purposes of conversation, it's probably important. So Medicare Advantage is obviously a subspecies of fee-for-service, or rather it's an alternative to fee-for-service. When you're a Medicare beneficiary, you get in fee-for-service, which is the vast majority of beneficiaries, but you can choose a private option where you get a plan that will offer the same fee-for-service benefits under A or B, but in exchange for that, you have to go to a network. A certain number of doctors and hospitals. It's not just the general assignment of doctors and hospitals that you can get under fee-for-service. You take a more limited approach. Medicare Advantage plans. Now remember, Medicare does not cover dental, full stop. The Build Back Better plan may or may not do that, but that's a whole nother conversation I can kind of get to here in a moment. But Medicare Advantage is able to offer extra benefits, over-the-counter drugs, dental, vision, gym memberships, you name it, because of the funding mechanism by which they operate. Each county in the country has established a base rate. The Centers for Medicare and Medicaid Services. Maryland has no say, no control over this since it's a federal program. That base rate is established by the Centers for Medicare and Medicaid Services, and plans, Medicare Advantage plans, bid against that. If they bid below the amount of the benchmark, they don't get to pocket the money. That money has to roll back to the beneficiary in terms of reduced cost sharing, so forth. That rolling back of the delta between, let's say, $100 and $80 on which they bid comes back in the form of extra benefits, dental, a certain dental modicum. So all that is based on what they're able to do with the benchmark amount against what they've been bid. So it's an actuarial dynamic that we have no control over whatsoever in terms of the benefits they offer. Now, in terms of how Medicare Advantage plans operate on a county by county basis, is predicated based against what the baseline, the benchmark is established in those counties. And again, they have a benchmark they have to hit. And when they bid against it, they think, can I develop a network in this county? How easy is it for me to establish discounts and so forth, such that I can come in under the benchmark? Because if I come above the benchmark, can't operate, don't have the ability to do so. So it's kind of, they're restricted by the ability to develop networks and so forth by a county basis. The other confounding variable that we have here in Maryland is that we have rate setting across all programs. And so that has a profound impact across the financial negotiations that plans across the board and payers have with providers, doctors, hospitals, and so forth. So it's a kind of complicated, convoluted issue, but that's a big factor in terms of the offerings in the state. That's a little bit of a side, but to revisit real quickly on Medicare coverage of dental, there's been thoughts, and the House is going to vote on this week, and then the Senate will take it up at some point in the future. There were thoughts about offering maybe a voucher for Medicare dental benefits in the absence of a true bona fide or dental benefit covered under outpatient, because that's kind of off the table as far as where available. What's interesting to note is that the number that was circulated was around, and it's not bona fide right yet, is about $800. If you look at the average out-of-pocket costs and the average benefit that's offered in Medicare Advantage in dental, it's around $875, $835. So they're basically, the government, and the folks down the Beltway, I assume, are trying to benchmark it based on what's out in the private sector to try to import that out to a fee-for-service to make it more expansive. Because right now, the only folks that have dental, unless you have a secondary coverage in Medicare, are in Medicare Advantage. Sorry, the teacher in me couldn't help but take 10 minutes. Other questions?
I actually have another topic, if I may.
Please, Dr. Main.
So I know, Emmy, in 2017, the National Association of Dental Plans did a great study on chronic conditions, actually it was done with one of the professors at the University of Maryland. So it was kind of Maryland research. And it was showing an analysis of adults with Medicaid preventive dental benefits have lower medical costs for chronic conditions, as you alluded to. But I was wondering if you've updated that study since 2017 or have done any more work in that arena.
That's a great question, Dr. Romain, and I so appreciate plugging that report. We have been working with Columbia University now with the blessing of Dr. Mansky to look at the collection of that data, but then also go a little bit more of a time series through the implementation of the ACA and as states have sort of changed or updated their dental benefits in Medicaid. And so we do have more updated information, I think, that does kind of confirm that previous hypothesis or finding. I can't say much else about it before it actually gets released. But Columbia University and the partners that we're working, and the folks, the experts that we're working with now are looking around kind of right now for publication. So hopefully that will happen soon. But yes, we have been working to provide additional information and kind of updates from that 2017 report.
Lindsay, can we drop the presentation for a moment before we tee up Bernard so we can see if there's any other questions? It makes it a little bit easier. Thank you. Other questions from the task force? Okay, then I would suggest that we move on to Bernard's presentation. Mr. Lepine.
Sure, and I just want to thank you all for having us here again. I appreciate your time, and what I'm here to do is to really give you the carrier's perspective. I know we touched on that briefly, and provide you with some specific information about United Concordia, and I will tee up my presentation now. Hopefully you can all see that. Looks good. All right, just to give you a little background about myself before I begin, as Matt indicated, I work for Highmark Health and support United Concordia Dental. I've been in the insurance space for many, many years, over 25 years, and landed with Highmark back in 2014 and have been working with Highmark and United Concordia Dental ever since then. And as I said, what I'm here to talk about is really to give you a specific overview about United Concordia Dental, what its enrollment looks like, both on a national basis and in Maryland, some information about its products, what we see as some employer purchasing trends in the state, touch on provider network. I know you discussed a little bit about provider network and access, expand upon some initiatives that Emmy talked about related to oral health and medical dental integration, and then just share some information for you about United Concordia's community support and some programs it's supporting in Maryland as well. So to start off, this just gives you some really high level information about United Concordia. Many years experience as a dental only carrier, just over 9 million members across the country, focused on having a large and robust provider network. And, we really think of United Concordia now, and it's really transitioned over the last several years as an entity that's more of a dental solutions company rather than a dental only carrier. And you should also know that United Concordia is a subsidiary of Highmark Health, which is a large Blue Cross plan that serves members in Pennsylvania, Delaware, West Virginia, and parts of New York now. And really, that's been beneficial when we consider some of those studies you talked about in medical dental integration. It's been really beneficial to have a parent where medical claims are available, and it really helps progress and analyze some of that information when we look at the oral health and overall health connection. So talking about sources of coverage, I wanted to provide you with a snapshot of what United Concordia's national enrollment looks like. As I mentioned, just over 9 million members across the country. Its largest segment, it's still its commercial business at about 38% of that total. Now, I would say here that United Concordia is only in the group market space. It does not offer individual products. But of that commercial enrollment, 60% of it is self-funded business, 40% is fully insured, and a much higher number than what the Emmy with the NADP presented. About 94% of its business is PPO. So again, still being the most popular plan that is being purchased out there in the commercial segment. United Concordia does offer DHMO plans in various markets, including Maryland as well. But PPO dominates its business and its sales. Interestingly, though, and this is where the dental solutions company, kind of comes into play, is its partnership business. And when I mention partnerships, I think of those things, some of those things you just talked about. So United Concordia does partner with various medical partners to help administer dental products that those medical partners offer, such as in, you talked a little bit about the Medicare Advantage space. United Concordia has several relationships with different Blues plans in different states to administer dental products in those Medicare Advantage products, which has been successful. It also supports some of their Affordable Care Act products, and as well as supports managed care medical plan Medicaid products in Pennsylvania and in Delaware that both offer dental benefits in those states. United Concordia also administers the Department of Defense TRICARE dental program that has some significant membership to it, and then it offers plans through the FedVIP program. So a lot of experience in a lot of different spaces throughout the country. Specific to Maryland, that's a significant state for United Concordia, with about 412,000 members. About 75% of that is commercial business, and again, largely dominated by PPO plans and employers purchasing those PPO plans. It also has a more significant proportion of its business being self-funded, but that may be a little misleading because United Concordia is the administrator for the state of Maryland business, which brings with it a lot of membership as well. It also recently offered and supports products for the city of Baltimore. But the rest of its business, about 100,000 members, are made up of folks enrolling through the TRICARE dental program or through FedVIP. So hopefully that gives you a pretty good outlook of what its business model looks like in the state and nationally. Turning to products, I categorized United Concordia's products three different ways. One, there's commercial plans. So these are comprehensive dental plans that offer flexible plan designs. Emmy talked about a couple of these. Again, PPO is the most popular, but there's also DHMO and some discount products as well. And when we think of PPO products, we really categorize them into two different types. One is an active PPO, and that's where there's differentials between in and out of network services. And passive PPOs are just that. There is no differential. It's the same cost sharing generally for in and out of network. Innovative solution products. So those are products that really, have focused on that research that you talked about, that focus on oral wellness and overall reduction in costs. There's a couple different ones I'll give you examples of. A chronic condition gum disease benefit. That's not the most eloquent saying, so it's better known as Smile for Health Wellness. And there's a related pregnancy benefit that goes along with that. And I'll talk about those on the next slide. There's an annual maximum rollover product, which really focuses on making sure consumer members get an annual exam, and then if they do, they're eligible to roll over a certain portion of their unused annual maximum. There's a preventive services incentive benefit that really excludes certain preventive and diagnostic services from the annual maximum as well. So those are really products that, again, focus on oral health and overall health. And then from United Concordia's perspective, there's what we would call value plans. These are really lower cost PPO plans, generally passive PPOs, that still offer flexibility to employers related to cost and provide higher levels of coverage generally for preventive and diagnostic services and lower coverage amounts for some of the other services as well. But again, the key is that this is all related to meeting employer needs and providing them with the flexibility to purchase the products that fits their needs the best. And underlying all of this, of course, is the provider network. It's very significant to United Concordia as it is to other dental carriers. Very important to carriers' client base as well. And it's important because it does bring network savings and discounts, resulting in lower costs. Dental plans, like medical plans, have quality assurance programs, utilization review programs, credentialing requirements that help promote consumer protections. Potentially help improve service outcomes, provide for professional review of claims, and then, really help protect members and consumers from balanced billing as well. And I want to give you a little more information about the Smile for Health Wellness products that I spoke of, because again, these really tie into the research and the link between oral health and overall health, and they're really designed very much for that purpose. Generally speaking, they focus on certain health conditions or pregnancy and provide an enhanced benefit to help promote that overall health, because we know that there's a correlation, as I mentioned, between certain chronic conditions and someone's and gum disease, for example. And you can see some of those conditions that I have there, and providing this enhanced level of benefit has been of interest to employers and very beneficial related to this as well, and potentially reducing overall costs. Pregnancy benefit is a similar concept. We know that pregnancy can adversely affect periodontal health. Again, providing enhanced benefit and enhanced level to help treat and ward off long-term periodontal disease. Just turning to purchasing trends in the state. Again, Emmy touched on this a little bit, but specific to Maryland, I asked our sales folks, what are they seeing in the market? What is the trend? Where are things heading? And as opposed to at the national level, in Maryland, the preference has been for active PPOs, where nationally we see more of it related to passive PPOs. So active PPOs, again, employers asking for differentials between in and out of network services. We have seen an uptick in plan designs related to exclusive provider organization products, maybe to compete with DHMOs at a lower price point. Again, these types of products would have a narrower network, generally only in network services. And again, it may be valuable to employers to have such a lower cost product available to them. We've seen requests for higher annual maximums. Generally speaking, 1,500 seems to be a pretty popular maximum in the state. We've seen employers ask for higher annual maximums. Employers are clearly interested in incentive-based benefits, some of which I spoke to, such as related to preventive services or the ability to roll over annual maximums, as I spoke to, and benefit designs like those. And then certainly employers are interested in and very much aware of the oral health initiatives that we talked about. A focus on reducing costs. Of course, employers would be interested in reducing overall healthcare costs and the importance of oral health in doing that. Turning to the provider network, I wanted to give you a snapshot of what United Concordia's provider network looked like in the state of Maryland. And I think this just emphasizes some of the things you are discussing as well. And I would say traditionally dental plans have been interesting in offering, very large and robust provider networks to their clients. Their clients have demanded it, and it's a very important part of their product portfolio. As I mentioned, there may be a trend towards more narrow network products, potentially because of cost savings. And you probably all know that Maryland does have a dental network adequacy regulation that regulates distance standards related to what networks have to meet in the state. And there's an annual filing requirement related to that. And it's measured on an urban level, a suburban level, and a rural level. And you can really see, I think this really just demonstrates the differences. You can certainly see a large concentration of dentist locations. And here, this is for general dentists within urban areas. But of course, when you look in the western part of the state and the eastern part of the state, there's not quite as many locations for general dentists. You can see the same pattern with specialists. It's the same very much pattern, same very much issues with dentists actually practicing in those particular areas. And that kind of leads into United Concordia and I'm certain other dental carriers exploring alternative ways to provide access, potentially such as using mobile dentistry to deliver services and bring those services to the community. United Concordia has partnered with a couple of different service providers to help do this. It's partnered with its Medicaid medical plan partner in Pennsylvania to bring mobile dentistry to different areas of the state. It's supported a Mission of Mercy program that does the same in Maryland, and the results have been really positive there. Teledentistry is another thing United Concordia is looking at and other dental plans as well. We definitely saw a significant uptick in the amount of services and claims that we received during the pandemic regarding teledentistry. Those have dropped off quite a bit, but I certainly think it's one way that plans like United Concordia can continue to explore to help promote access, again, related to its Pennsylvania Medicaid business. It's helping to promote and set up locations regarding teledentistry to help deliver services to its members. And I know we already touched on dental medical integration. I just want to speak briefly to some of the research that United Concordia has been involved in. And this is a little bit older, but back in 2014, United Concordia worked on a study with Dr. Jeff Coate with the University of Pennsylvania that spoke to what you were discussing, that looked at certain chronic conditions and whether or not treatment of gum disease related to individuals who had those conditions could ultimately lower overall costs. That study was published in the American Journal of Preventive Medicine and certainly did conclude that healthcare savings can result as a result of treatment of gum disease. In 2017, United Concordia did a little bit different study and looked at what is the value of going to the dentist and looked at individuals who make regular visits to the dentist versus those who do not. And in collaboration with its parent Highmark, looked at medical claims data and concluded that certainly, yes, there are annual healthcare savings when folks regularly visit the dentist. And you just talked about a recent study with the NADP as well. And, certainly I think what's important here is that because of the conclusiveness of those studies, it's really driving dental plans like United Concordia to design benefits, to provide that oral health education and to make those available to their clients because there are potential overall savings. This slide just gives you some information about what can be lost related to potential health problems and how oral health can certainly address some of those. 84 billion is a lot lost by U.S. businesses each year due to absenteeism because of health problems. 184 million hours lost due to unexpected absences. We know that a lot of diseases can be detected through the mouth. So again, a strong correlation between oral health and overall health. And I'll end with some information for you about the United Concordia Dental Charitable Fund and some of the community support it's providing, because I think it also goes to oral health access. We're really proud of this one. This was a recent formation as well in December of 2020. It stems from the Highmark Foundation, and it's really focused on charitable activities. Charitable activities related to supporting oral health in the communities in which United Concordia participates. And in that, it's focused on workforce development and those types of programs related to oral health, dental care for the uninsured and underinsured, and certainly diversity and inclusion initiatives related to oral health. It's really focused on providing 10 million or more over the next decade to support those initiatives. Some current initiatives include dental scholarships, such as providing, I think over the course of the next several years, United Concordia plans to provide over $1 million for scholarships related to Howard University and the dental school, Meharry in Tennessee, and to support diversity in the dental practice and in the dental field. United Concordia also continues to support an organization called Team Smile, which partners with professional sports organizations to help provide free dental programs for kids. Excuse me. And then, there is a RFP proposal process to focus in on oral health equity and social determinants of health to help support community organizations and dental programs that focus on uninsured and underinsured individuals to help promote those. And I would just leave you with the last slide, which gives you some additional information about those programs and let you know that, again, United Concordia is committing to support these programs, such as with the Maryland State Dental Association, the Mission of Mercy clinics, mobile dentistry, and those types of initiatives. So that's what I have for you today, and wasn't sure if there's any questions in the chat or if you have any questions for me.
Bernard, appreciate it. Let's see if we can drop the screen.
Yep.
Thank you.
There you go.
Thank you. The questions, Dr. Verma.
Yes, thank you. Thank you for your presentation.
Sure.
I have two questions. One, the mobile dentistry outreach that you're conducting, has that already begun or is that in a planning phase?
No, that's already begun.
What areas of the state is it servicing?
There were in Pennsylvania, there was a couple different locations. I know Harrisburg was one, and it was I'm trying to remember the numbers for you, but I think it served over 800 members in the state with mobile dentistry there. In Maryland, I know I have a list of the counties. If I can find them real quick and some materials I have prepared here for you. I don't have that in front of me, but I can certainly get back. I know it was 4 different locations in Maryland. I think Tanyatown was one of them. There was a couple others, but it was 4 locations. Again, that was sponsoring a Mission of Mercy mobile dentistry clinic in those particular areas.
Okay, and my second question, you had mentioned that you have plans that support innovative solutions. How many employers are selecting those types of plans? And is that something that an individual in the plan can select or the employer has to select? And as a follow-up, the rollover on the annual maximum, what % is actually available for rollover?
Yeah, as far as your first question, it depends on the product and the plan. And for some products and plans, that benefit would be automatically included. In others, employers can select it again. We're trying to design products and plans that are flexible, that again meet employer needs, but it's been very popular. On the annual maximum rollover, that's at about that the eligible amount to rollover is $300, and again that's if you have an annual exam during the year. Does that answer your questions?
Yes, thank you very much.
You got it.
Other questions before I jump in the queue and ask mine? Question for you then. I know that you have a diversity of payers, and one of them being TRICARE, and obviously TRICARE, VA, larger federal payers tend to have their idiosyncrasies in terms of payments and in terms of where they, oh, I'm sorry, Delegate, do you want to ask your question first? I always defer to a delegate before I decide to jump in.
That's okay. I appreciate it. And you may not have the answer to this question. I'll admit I'm actually slightly embarrassed. I don't have the answer to this question. But you know, we were very successful with the reinsurance program, the reinsurance legislation. And maybe Matt, you know the answer to this. Do you know how that impacted the oral care insurance market?
I'd be happy to take that one, Delegate Bagnall, and thanks for the question. So the wildly successful reinsurance program that sort of saved the individual healthcare market from the point where we were worried about it staying solvent was funded with an assessment on carriers. It originally was a 2.5% tax on any insurance carrier in Maryland in the health space. And then in the second year, once we realized how much money we raised, it was reduced to 1% for the continuation of the 5-year waiver. Unfortunately, that 1% carrier tax was extended to dental and vision plans who can see no benefit from the reinsurance package in dental benefit structure. It was only for health insurance products. So dental carriers had to absorb a 1% carrier tax, but could get no benefit from the reinsurance program. And we are hoping, and we think that there is no carrier, there is no carrier that is against reinsurance, and we are up on the end of the reinsurance program at the end of calendar year 23. But the states that have moved forward with reinsurance programs after Maryland had successfully gotten their 1332 waiver, all of them exempted vision and dental from the carrier assessments if they took that course of action for funding. That would help keep premiums low and lower. As Bernard and Emmy had discussed earlier, the dental market space is a pretty solid. We don't see wild spikes in premium assessment, but that 1% is a pass through to consumers. So the carriers do not just sort of eat that cost. It's directly passed through in premium to folks that are buying dental coverage. So to get rid of that 1% should have a positive impact actuarially to premiums in the future.
Thank you. And thank you, Mr. Schechter, for giving me the opportunity to ask that.
No problem. I'll give Dr. Quinlan the same latitude.
Thanks, Alex. You know, this is just a comment I had for the entire task force. I mean, you know, as I write down these notes and we kind of go through these presentations and things, I think one of the things that surprises me a little bit, and I don't know that in my estimation, the hardest part to fix about this whole problem is I feel like sometimes oral health and dentistry is not taken as seriously as medical care. When we talk about things in the previous presentation about how, the benefits are less than what medical usually pays. The Surgeon General kind of is no longer commenting on dentistry, and they've kind of moved that to NIH. When we talk about reinsurance, there was no benefit to that. So, when I see statistics too, as far as education of families beginning to go down with oral health, we kind of seem to be in this trajectory of a sort of downward spiral when it comes to dental. It's like not that I want to talk about fees and it's about money all the time, but there just seems to be this thing where, dental plans are super cheap to sign up for. And, there's just like not a ton of money going into it. And then we're wondering why sort of there tends to be this, decrease over time as far as, utilization, education, things like that. So I'm saying it now because I think as we talk about sort of the state of Maryland, we talk about whether it's private insurance or Medicaid or what have you, I think it's really important for us to kind of somehow get over this hump that, dentistry truly is important. If we're really pushing this agenda of dentistry leads to overall not oral healthcare, but overall healthcare, I don't think we're going to get over that hump until we actually really start changing the way the system's a little bit. And so as some of this stuff came out a little bit, I just wanted to make that note. Thank you.
Thanks, Dr. Corman. Dr. Dow.
Thank you. So I'm from Maryland Higher Education Commission, so I'm thinking about our college students. And as you may be aware, you know, the demographics of our college students are becoming more and more non-traditional, more and more not the 18 to 24 years old. We have returning adults. We have a wide variety of individuals, you know, immigrants, non-documented individuals accessing our colleges and universities. And so to piggyback on that, so I think this is a comment more than anything, thinking about how we can engage college students wherever they are in their lifespan and educating them about going and getting your annual checkup or going and getting your cleaning. I had joked in the preparation of all of this, you know, maybe we do a campaign of when you're registering for classes, go and make your appointment to get your cleaning. Things like that may be helpful to engage people within the broader community around oral health. I think there's opportunity there. And so I'm thinking from how we engage our college students writ large around these efforts. And so then I have a question that I think is just a broad question, not necessarily to be answered here. I certainly understand that for the traditional college age student, 18 to 25, most of those students are likely still on their parents' plans in some way, shape, or form. But for the students who are not, I don't know. I personally don't know. Our commission does not necessarily know. We don't get into these kind of details around student affairs and student activities, but what kind of access do they have? And are they getting educated? Certainly campuses offer student health insurance, but I don't know if that student health insurance includes dental plans. So that's another kind of consideration that's reeling through my head and listening to these presentations. And I'll stop there. Thank you.
Yeah. Thanks, Dr. Dow.
Alex, do you mind if I jump in there?
No, please go ahead.
Yeah, thank you. Emily and Dr. Koyman, I really appreciate your comments. And I would say, Dr. Koyman, that the fact that this commission passed and this task force is going to exist and come out with recommendations, I think shows that there is a general commitment from the General Assembly and others to continue the work to sort of take away whatever quote unquote stigma might exist around dental care. I think that it would be important to continue or to recommend that continued education as a part of what we need to do to move forward will be important. Emily, I will say to your question about students, I think you hit the nail on the head. Most college students, because of the Affordable Care Act, are going to be able to stay on their parents' insurance till 26. But to the non-traditional, age students, thank you to Delegate Bagnall and others and their committee. We just passed a brand new young adult subsidy program from the General Assembly this year. And if you are up to 35, you are going to be able to go onto the exchange if you don't have group coverage and buy products that are really inexpensive because of this extra subsidy that's being pulled out of the reinsurance program to help folks, younger folks, improve the risk pool and to be able to afford coverage where they might not be able to. And we're right in the middle of open enrollment right now. So if you have some students that need coverage, they should go take a second look, because we are hearing stories of folks that are getting really great coverage for like $8 a month. With that, I'm sorry, yeah.
Yeah,
please.
no, this is great. I'm sorry to interrupt you. If you can send me information, I will get it out to the masses. We have a student advisory council. We work closely with all the presidents. I can get a memo out today and make sure that communication gets out, at least from our agency. I'm sure there are other venues, but we can just echo that sentiment. So if you can send us that's great.
Yeah,
that is good news.
Happy to. I mean, I know Lindsay and Tyler, the staffers, worked really hard with Delegate Bagnall on this bill and their committee this past year. And the Maryland Health Connection is enrolling folks right now. I will say, in addition to the young adult subsidies, and we can send you that information, there are a lot of additional subsidies coming from the federal government because of the American Rescue Plan. There is more help on its way, especially in the individual market. We also believe that there's going to be additional help on top of that that's coming from whatever passes in reconciliation from the Build Back Better Act. With that, we have a surplus in Maryland because of all that federal money that is coming our way, $2.5 billion that the state of Maryland is setting on that we could be utilizing to increase coverage. And like Bernard and Emmy had said before, we know that if people have coverage, they get better care and they have better healthcare outcomes. So there is reason to be optimistic. And I am usually a glass half empty type person. But in this case, because we're all here and we're having these discussions and we have all these different stakeholders at the table, I think there is reason to be optimistic.
Thanks, Matt, for that shout out to the Maryland Health Benefit Exchange. So remember, open enrollment goes through the end of the year. Dr. Doran.
Thank you. Talking about education and for the school kids, we at Maryland State Dental Association worked with a state delegate, I believe it was 2 years ago, on a bill that would require school-age children to get dental exams at certain ages. I had done some research looking at various counties and Baltimore City and what was required. At that hearing was over, and I believe it was Economic Matters, so it didn't go to HGO because of school funding issues, but we didn't gain any traction on that, which really surprised many in supporting this, because the school nurses came in saying, you know, we're really overworked. This was pre-COVID-19. And I think if we're gonna kind of educate the students, staff at schools, and the parents, these kids need to be examined periodically. And that may be something for that younger group subcommittee to look at and maybe come back with recommendations on dental school exams to make sure these kids are checked prior to school starting and they don't develop infections in the middle of the school year. So I just wanted to add that we've tried in the past and we've hit roadblocks with various groups that just don't want to be overworked. Thank you.
Dr. Doran. I'd like to go back to what Dr. Coleman said about, you know, the importance of dentistry and how it's kind of lost in the larger milieu of healthcare costs. You know, dentistry is about 4.5% of all total healthcare spend. 60% of healthcare spend is in three silos: doctors, hospitals, and pharmaceuticals. So you're fighting two different battles there. Number one, you're fighting the battle of it's a smaller portion than the bigger cost centers, so people are going to naturally gravitate their attention towards the larger cost centers and try to squeeze those down. And the second one also becomes, to a certain degree, is the fact that because it doesn't have right now coverage under Medicare, you lack that precipitating effect that happens when Medicare decides to cover something. It creates fee schedules, it creates coverage determination policies, and so forth. It develops an architecture for what should be in, what should be out, and how to pay for it. In the absence of that mechanism, it becomes harder for any payer to figure out how to pay for dental, and it becomes hard for those payors decide also not only how to pay for it, but what quantum of benefit they should offer, what's appropriate. And that goes to the third aspect, which is the ROI, right? The return on investment, the long-term quantitative impacts on healthcare. You get a stent, you know it's going to keep your artery open and presumably prevent a heart attack. You take an anti-lipidemic, it means it's going to drop your bad cholesterol. Dentistry is immediate, but also long-term for chronic. And so getting to that evidence, getting to that, that understanding of the long-term prospects of the value, not necessarily in the 5-year immediacy, 10-year, but long-term, those are the three hurdles that are kind of omnipresent and are not just restricted to this task force. So I'll give up my soapbox and ask for any other questions. Lindsay, do we have anyone teed up for public comment?
We do not.
Okay. So last call for questions here before I go into announce or conversations about future meetings.
I have a question.
Please, Dr. Hughes.
So, how was it determined and who determined it that at age 26 that coverage should stop for dependents?
That was probably just a fiscal decision during the Affordable Care Act of what they can make work. So everything comes with a cost estimate, and if probably 26 was the cutoff, and say, hey, this will cost XYZ millions of bucks. I think, Matt, you can check me. I think it's 2 million lives, maybe up to 4 million that have people who have availed themselves of coverage on their parents' insurance. And so it was little bites of the apple: expansion of the creation of the exchange market, expansion of Medicaid in those states that decided to avail themselves, adding kids, well, maybe not kids, but 26 years old to their parents. So, kind of whittling away at the time, which was 30 million uninsured before the Affordable Care Act passed.
Yes.
It's a cost-based exercise.
Yeah, I have nothing to really add. I will just say that prior to the Affordable Care Act, Maryland had already moved forward in the General Assembly's wisdom and allowed Maryland kids up to the age of 25 to stay on their parents' insurance. So it wasn't that much of a change with the ACA in Maryland.
And to our credit as well, I will also say that vis-a-vis the Medicaid expansion as well. There were a number of states, 10 states had already expanded Medicaid prior to that additional enhanced match coming from the federal government for expansion. So,
we went a little bit higher. We went to 116% in Maryland prior to the ACA, and the ACA took us a bit more. But yes, Maryland is always ahead of the curve.
Questions? Or hearing none, and Dean, please jump in here. At this point, what we're doing is teeing up additional, besides the work group efforts, we're having a pipeline of speakers that we again feel would be informative rather to our discussions. And thank you to our speakers today, Matthew. Thank you, extraordinarily helpful. Again, it helps to expand upon the purview of what we're looking at. And so we are teeing up potentially to have the American Dental Association Health Policy Institute come and talk about some of their surveys and studies. They do, as you're probably all aware, a cost survey across dentists across the country and regionally on rates that are paid. Have the industry, the managed care plans come to speak about what is offered in the Medicaid space, how they use and how they plot their dental benefits, and perhaps gets us some utilization data there. Again, don't want to exclusively focus on Medicaid, but Medicaid is obviously the biggest payer and has a kind of the biggest bang for your buck. But again, this is an optional benefit, so it comes from general revenue, and so there are always fiscal considerations that come into play. So those are the types of conversations and speakers that we have. We're also looking to get some of perhaps the local health officers to come and talk about on the ground experiences to give a taste of the geographic disparities and what's going on in one of our 24 counties, different ends of the old line, and so on and so forth. So we're going to plot these out. We'll tell you about who we're thinking of bringing, and also invite you to provide additional suggestions, especially as they relate to informing your subgroup efforts. Other questions or comments or suggestions? Dean or Delegate Bagnall, or anything you'd like to provide closing remarks before we disband for the day?
Delegate, I'll defer to you.
I'll just say once again how much I appreciate this group coming together and really looking strategically and and analytically at the big picture issues that are creating barriers, so that we can work to identify and remove those barriers to care. I do take the concerns that were brought up about making sure that we are looking at oral care as an essential part of healthcare and preventative care, and not as an additional or an augmentation. And I'm thinking strategically of how I can work with the health department and with stakeholders in the somatic care world to see how we can also work to change the perspective on the essential nature of oral care.
Thank you, Delegate. Well, with that, we'll make a quick announcement. Our next meeting that we've all agreed to will be December 2nd from 4 to 6 o'clock. It will be a non-voting meeting, and you are able to send proxies if you can't attend. So please let the staff know if you intend on having a proxy during that time. It will, of course, still be recorded, so you'll have be able to avail yourself of the recording and the conversations there too. And then our next standing meeting will be on the 16th. Of December. I don't know that we have the time yet, Lindsay, or do we? Is it 10 to 12?
That's regular time, 10 a.m.
10 a.m. to 12 on the 16th. So with that, any other questions, comments, suggestions? I wish you all a happy Thanksgiving and stay safe. Thank you all. We are adjourned.